So good afternoon all. Welcome to our third session. Today we have Dr. Mary Abraham taking a session on management of pain. So we can start with ma'am's presentation. It will be there around 45 to 50 minutes, followed by 15 minutes of discussion. We can start our case presentation by 4 o'clock, followed by its discussion. We can wind up our session by 4:30. So over to Dr. Sridevi.
Hi, welcome you all. Glad to see you all again this Monday after a fruitful discussion on last Monday. So we have with us Dr. Mary Abraham. She's an anesthetist by profession working in Delhi. She was with us for 6 weeks training years back in Trivandrum. So very good friend of ours, and she's one person who will never say no whenever we call to take sessions. Whenever we need some help, she's there to help us in training. And it's very good to see you again and again, ma'am. Welcome to the Eco session. And I guess that she was on doing some procedure till 2:45, 10 minutes back. Yeah, she just finished the procedure and came for a session, which is really commendable. Thank you so much.
Thank you so much, Sridevi. And like I said, I'm ever ready to do it because is my voice audible?
Yes, ma'am. Yes.
So it's because I have this attachment to pallium. Okay, that let me be frank about it. And I really would like to help out in this. And it's indeed a real pleasure to be again and again on the ECO program. And whatever little I can do, I am trying to do. So it's a pleasure is mine, actually. Okay. Right. Then can I start my presentation?
Yes, ma'am, you can.
Okay. First slide. Okay, next slide. Next slide. Next slide, Rajalakshmi.
Ma'am, 1 second.
Okay. Okay.
Ma'am, can you see it now? Yes, ma'am.
Yeah, I can see it. Yeah. The one before this. Okay. So I will be talking on pain management in palliative care, because in palliative care, about more than nearly 60 to 70% of patients have pain, and it forms a major symptom that we need to treat. So, and particularly in end stages, in the advanced cancer, up to 90% of patients can suffer from pain. So it's so important to know how to manage pain. And the broad outline of my talk is, I will be talking about the WHO analgesic ladder, and I will be discussing only the step 1 and step 2 drugs of the WHO analgesic ladder. And along with that, I will be discussing the adjuvant drugs that you give along with these drugs, and particularly with some emphasis on drugs for neuropathic pain. Next slide, please. Now, there was an International Pain Summit of the International Association of the Study of Pain in 2010, and there was the Declaration Montreal, in which many countries had were signatories of that declaration, in which it was a document was made that access to pain management is a fundamental human right. Now, this is quite compared to what it was being taught earlier, that pain management is optional and people need to suffer pain, people need to bear pain. If I have cancer, I have to bear pain. If I have surgery, I have to bear pain. It was actually a contradiction to that, because then they said that every person, the access to pain management is a fundamental human right. And next slide. And according to the international human rights law, countries have to provide pain treatment medications as part of their core obligations under the right to health. In addition to treating the disease, even pain management is also an obligation by the healthcare provider. And it goes one step further. failure to take reasonable steps to ensure that people who suffer pain have access to adequate pain treatment may result in violation of this obligation. And it is in fact deemed cruel, inhuman, and degrading treatment. That are pretty strong words. Okay, that is denial of pain management. Denial of suffering is actually a violation of the rights, and it is deemed cruel, inhuman, and degrading. And cancer pain is now a health priority, and the World Health Organization has developed policies and strategies to treat it with an emphasis on total pain management. Next, please. So the vision of a palliative care physician would be that every person suffering from a life-limiting or incurable disease in India and in the world over has access to effective pain relief and quality palliative care. So that should be our core obligation to every person suffering from cancer. Okay, next please. So a very important way of managing pain, in fact, this is basically the sheet anchor, is the WHO analgesic ladder, which we should all be familiar with. The WHO analgesic ladder was actually made based on the recommendations of a group of international experts. One of them was Dr. Twycross. In fact, Dr. Twycross is a very close friend of Pallium, and he has even visited Trivandrum several times. When I was doing my training, he had come, and he was one of that core group that actually made this analgesic ladder. So it is a stepped ladder approach, and it was made in 1986. It has been translated into 22 languages, and it has served as a catalyst to treat cancer pain worldwide. Next, please. So it is a very simple, validated, and effective tool to manage cancer pain. And it is a stepwise approach to treat pain depending on the severity of the pain. Prior to this analgesic ladder, many patients were dying with unnecessary pain. And what was the cause of that? First of all, there was a lot of drug regulation regarding opioids, and it was not easy to procure the medicine. And secondly, there was also stigma attached to prescribing opioids and also taking opioids. People thought that only addicts, you become addicting and things like that, But when the step ladder approach of the WHO analgesic ladder was made, it actually legitimized the use of opioids, because opioids is the step 3 of the WHO analgesic ladder. Next, please. So before we go on to the WHO analgesic ladder, we should assess pain, because that is based on the severity of pain. So how do we assess the severity of pain? For that, we need to assess the pain. First of all, we should know whether the pain is nociceptive or neuropathic. What is nociceptive pain? Nociceptive pain is pain secondary to a tissue injury, in which the pathway of conduction of the pain is normal and the pain is perceived in the brain because of a tissue injury. Like, for example, you have a cut in your hand, and that is conducted through a normal pain pathway up to the brain, and you can feel the pain in the cut. Or we have to also see whether the pain has a neuropathic element in it. Neuropathic is, there may not be a cut, or the cut may be so small, but the pain is so severe. That is because the nerves that are conducting this pain to the brain is actually abnormal. So the nerve conduction has become dysfunctional. So pain that is conveyed through a dysfunctional pain pathway is called neuropathic, and that has got several characteristics which I will discuss later. So first of all, you should know, when you see a patient with cancer, is it nociceptive, or is it neuropathic, or is it a mixed? Sometimes you can have both nociceptive and neuropathic elements. Then we should know what is the intensity of pain. Is it mild, moderate, and severe? Now, to say mild, moderate, and severe may be a little difficult for patients. So we have various scales to measure the pain. And one is the visual analog scale, and the other is a numerical rating score. So this will come when they are telling you about the assessment of pain. So I will just say that it is a numerical rating score from 0 to 10, and based on the number, you can assess whether the pain is mild, moderate, or severe. For example, if the score is less than 4, it's considered mild. Between 4 to 6, it is considered moderate, and more than 7 to 8 is very severe pain. In fact, 10 is unbearable pain. Next, please. So once you have assessed the pain, then we have to apply the ladder to that. So if it is a step 1, it's meant for mild pain. Okay, maximum moderate pain. And the step 1 is actually a non-opioid analgesic along may or may not add an adjuvant, depending upon whether there are other characteristics to the pain. Now, if the pain is not responding to the step 1 drugs, then, or if the pain is in the moderate variety, then you may have to go to the step 2 drugs. And step 2 drugs is a weak opioid along with a non-opioid analgesic with or without an adjuvant. Sometimes it doesn't respond to even step 2 drugs, or in the beginning itself, if the pain is very severe, the rating is around 8 to 10, then we may have to go to the step 3 drug. And step 3 drug is a strong opioid like a narcotic along with a non-opioid analgesic. So non-opioid analgesic is a common denominator in the step 1, step 2, and step 3. And you may or may not add an adjuvant depending upon the quality of pain. So this is the stepwise approach to treat cancer pain, or for that matter, even other kinds of pain. Next, please. So with using the using the step-wise approach to treat pain, you can treat 71 to 76% of cancer patients. The next is this: what are the salient features of the WHO ladder? The characteristic of the WHO ladder is, first, it is all the drugs are given by mouth, that is orally. The oral route is a standard route even for the step 3 drugs or the strong opioids. So the advantage is that it can be used for home care. So these drugs can be given by the mouth and can be given by the caregiver of the patient. The second salient feature is it is by the ladder. So you start from step 1, and according to the severity of pain, then you move up to step 2 and step 3. Then the other thing is that it is given by the clock. By the clock means it is given not depending on when the pain is happening and then you give the drug. You give it according to the duration of action of the drug, not on a PRN basis. Because if you give it on a PRN basis, what you have a breakthrough pain. That is when the duration of pain relief is exceeded and its limit is crossed, then the patient again has pain. So by giving it according to the duration of action, you're able to prevent the breakthrough pain. So if a drug has to be given 4 hourly, you have to give it at 4 hours. If you have to give it 6 hourly, you have to give it at the end of 6 hours. You do not wait for the pain to come to give the drug, but you give it according to the clock. The next characteristic is it is individualized to the patient. So the right dose is the one that relieves the pain. It could be a non-opioid drug, it could be an opioid drug, but whatever it is, if the pain is relieved, then with that particular dose, that is the right dose. It could be different for different individuals, depending upon the pain threshold of the patient and all. And once and we have to titrate the dose till the pain relief is achieved. And in fact, we should also treat the breakthrough pain. Even if you're giving it 4 hourly, like for example, you're giving morphine every 4 hours, but at the end of 2 hours, if the pain is recurring, then you have to give instructions that you can repeat the morphine. So that can vary from patient to patient. So that it should be titrated according to that particular patient, which can vary between patients. The next is that the adjuvant drugs are also given at every step. And that could be depending upon the type of pain. Is it neuropathic? Is there a muscle spasm? Or is there any other characteristic like, for example, abdominal pain, spasmodic pain? So the adjuvant drugs are also added alongside the step 1, step 2, step 3 drugs. And attention to detail is very important because depending upon the age, the comorbidities. Does he have a liver dysfunction? Does he have a kidney dysfunction? According to the drug interactions and the side effect of the drug, it is meticulously monitored. So that is a very, very important feature that we have to pay attention to when we are treating patients based on this ladder. Next, please. So what are the advantages of the WHO ladder? First is, like I said, it is very simple to follow, and it can be understood whether all over the world, whether you're in an advanced country or whether you're in an underdeveloped country. It has been well validated, which means if you follow it, it is effective and it is actually producing results. And it is also cost effective because all these drugs are given by mouth. And most of the drugs that we are using are relatively not expensive. So it is very economical. Then it can be implemented across the world, whether you're in the USA or whether you're in some parts of Africa or the remote parts of India, you can still implement this WHO analgesic ladder. Well suited for home care because these drugs can be given to the caregiver or by the patient herself, provided all the instructions are given properly. And it is not only applicable for cancer pain, but you can use it for acute pain as well as non-cancer pain. Next, please. So when we are, a comprehensive management of cancer pain means you should know all the steps, not only the step 3, but we should be familiar with step 1 and step 2 drugs as well as the adjuvant drugs, because the step 1 and adjuvant drugs are given at every step of the ladder. Next, please. Non-opioid and adjuvant drugs, I said, are used not only at step 1, but can be used at every step that you can see over here. You can use it here also and here also. And mild to moderate cancer pain responds to step 1 and step 2 drugs. And the adjuvant drugs are also given depending upon the type of pain and the quality of pain. And opioids may not be required. For example, many patients can be treated with step 1 and step 2 drugs. You need not even go to step 3 drugs if the pain is controlled. Next, please. But there are sometimes a little modification of the WHO ladder has been made over the years. Sometimes, if the pain is very severe, like I said, the pain severity is about 8 to 10 on the NRS scale, then you can omit step 1, step 2, and directly go to step 3. The other thing is, sometimes if the pain is very severe, not responding to all the 3 steps, then you may have to add a 4th step. Next, please. Next. So in 2000, the modification of the WHO ladder was done by adding a 4th step. And this is for the 10 to 15% of patients who are not responding to the step 1, step 2, and step 3. And what is the step 4? You can give certain nerve blocks, you can give an epidural injection, you can use a PCA pump, or you can do a neurolytic therapy with neurolytic agents like phenol or alcohol, or you can even do spinal stimulation. So there are a lot of advanced procedures and interventions that you can do in those patients which are not responding to even the step 3 drugs. So you can add a 4th step, and this was modified in 2000. Next, please. So let us discuss step 1, because I'll be discussing step 1, step 2, and the neuropathic drugs. Like I said, step 1 is used in mild to moderate pain, and these include paracetamol, non-steroidal anti-inflammatory drugs called NSAIDs, and with or without an adjuvant drug. Next, please. So let's discuss paracetamol, because this is the basic sheet anchor at every step of the ladder that we're using. Now, in India and Europe, it is called paracetamol, but in the US, it is referred to acetaminophen. So they are the same compound. It both contains paracetamol. Its action is predominantly central, and it inhibits the enzyme cyclooxygenase, which is called COX. And inhibition of this enzyme in the central nervous system leads to its antipyretic and analgesic action. Earlier, it was thought that paracetamol only caused antipyretic effects, but when you give it in the right dose, it even has very good analgesic effects. But the drawback is it has no anti-inflammatory action, unlike the NSAIDs drugs. Next, please. So what is a dose of paracetamol? It is safe at a dose of 12 to 15 milligram per kg every 6 hours. You can go up to 3 to 4 grams a day. It has a potential for hepatotoxicity, but even in liver disease, you can go up to doses of 2 to 3 grams per day. For pediatric purposes, you can use in the dose of 15 ml per kg every 6 hours. Toxicity with paracetamol occurs only when you're exceeding 90 milligram per kg per day. And this can be given not only with NSAIDs, but also with adjuvants for better analgesia. So it can be combined with NSAIDs and adjuvants. Next, please. So the advantages of paracetamol. Why is it so popular for treating cancer pain and in the WHO ladder? First is it has got a very good safety profile and the undesirable effects are uncommon. It has no adverse effect on the gastric mucosa and it is well tolerated by patients with peptic ulcers. It has no adverse renal effects. It has no effect on platelet function, unlike the NSAIDs. It is tolerated by 2/3 of patients who are hypersensitive to aspirin. And it even can be used in patients with gout who have got high plasma uric acid levels. As compared to NSAIDs, it has definitely got a better safety profile, and that I will discuss later. Next, please. Next. But there are some drawbacks of paracetamol. First is that it has to be given more frequently, like every 6 hours you have to repeat the drug for maintaining the pain relief. And if you give it in high doses of patients with impaired liver dysfunction, it has a potential to hepatotoxicity. But like I said, if you give in dose of 2 to 3 grams, then you may not have the side effects that are connected to the liver. And if the body weight is less than 50 kilograms, then you must restrict the total dose to 2 grams or 500 mg QID. So these are the few precautions that you have to take when you're giving paracetamol. Next, please. So like I said, why has it become the mainstay drug of the WHO analgesic ladder? Because of its safety profile, because of its opioid sparing actions. Secondly, it can be added to not only NSAIDs in the first step, but it can be added to the step 2 drugs like tramadol and step 3 drugs like opioids. So it is added at every step of the ladder. Next, please. So having said about paracetamol, let's now discuss the other step 1 drug, which is the non-steroidal anti-inflammatory drugs or NSAIDs. This is also a very commonly prescribed over-the-counter drug. It has got both analgesic and anti-inflammatory properties as compared to paracetamol, which does not have anti-inflammatory properties. So what are the indications of NSAIDs? It can be used as a step 1 drug. It can be associated, given with pain associated with inflammation, like a nociceptive pain where there is inflammation, like soft tissue infiltration or bony metastasis. And it can also be given in cancer-related neuropathic pain because inflammation can cause central sensitization and increase pain. So it can be given even for neuropathic pain. Next, please. How does the NSAIDs act? NSAIDs exerts its therapeutic effect by inhibiting the enzyme cyclooxygenase, but more in the periphery as compared to the paracetamol, because it has a central action. Now, this enzyme is a very important enzyme in the arachidonic acid cascade, which are actually producing the tissue and inflammatory prostaglandins secondary to tissue injury. And these prostaglandins are the important intermediaries in pain and inflammation. It is the prostaglandin which is actually leading to the sensation of pain. And it acts by increasing peripheral sensitization. So, NSAIDs is particularly useful in nociceptive pain associated with inflammation because it inhibits the action of prostaglandins by inhibiting the enzyme cyclooxygenase. So let us see how exactly it acts. Next step, next slide. Now, the cyclooxygenase enzyme exists in 2 forms. One is COX-1 and one is COX-2. Now, COX-1 is present in all normal tissues. It is called the constitutive or the housekeeping enzyme because it mediates physiological responses. It protects the stomach and has a beneficial effect on the kidney, and it facilitates platelet aggregation leading to the clotting. So it is present in all normal tissues, regardless of whether there is pain or not. Okay. The other enzyme, COX-2, occurs is inducible because it is only elicited when there is an inflammation. So if there is an inflammation, then the COX-2 is produced. And this causes the release of the prostaglandins, which causes the sensation of pain. So if you look at the arachidonic cascade, the phospholipids which are released as a result of tissue breakdown and injury produces arachidonic acid, which is acted upon by COX-1 and COX-2. And COX-2 is a protective enzyme which is present in the stomach and kidney and is responsible for platelet function. And COX-2 occurs only when there's an inflammation, and that leads to the pain produced due to the inflammation. Next, please. So NSAIDs are of two varieties. The first is the non-selective NSAIDs, which interferes with both COX-1 and COX-2. It inhibits both COX-1 and COX-2. Or the selective COX-2 inhibitor, which interferes only with the COX-2 and does not affect the COX-1. That means the beneficial effects are preserved and only the anti-inflammatory effect is added. So now let us discuss the non-selective NSAIDs. Like I said, it inhibits both COX-1 and COX-2, and the prototype of a non-selective NSAID is ibuprofen or brufen, diclofenac, but diclofenac can also be a COX-2 inhibitor. The other drugs are naproxen and aspirin. So the COX-1 inhibition causes, because it has a beneficial effect, the COX-1 enzyme, when you inhibit it, it will produce the adverse effect. What are the adverse effects? It causes GI side effects like bleeding. It can cause hypersensitivity leading to angioedema, urticaria, bronchospasm, and it has got adverse renal effects. Whereas inhibition of the COX-2, which causes this pain sensation, will actually have a beneficial effect. So it has the anti-inflammatory effect, analgesic effect, and antipyretic effect. So NSAIDs, by inhibiting both COX-1, which has a beneficial effect, and the COX-2, which has an adverse effect, is actually a double-edged sword, leading to both adverse effects as well as beneficial effects. So you have to choose how you have to use this drug. Next, please. The non-selective NSAIDs. So I said they inhibit both COX-1 and COX-2. So what are the examples of that? One is ibuprofen or brufen, which is given orally in a dose of 400 mg every 6 hours or 8 hours with maximum of 1 to 2 grams per day. The other one is naproxen. There are many, but I'm only discussing two. Naproxen in a dose of 250 to 500 mg every 12 hours. It can be given orally or as a suppository, and it is eliminated by the kidney. Next, please. So, what are the side effects of non-selective NSAIDs? This is because of the COX-1 inhibition, like I mentioned earlier. So, the gastrointestinal side effects are bleeding and peptic ulcers. Cardiovascular are increased risk of hypertension and heart failure. The renal side effects are sodium and water retention, acute and chronic renal failure, especially if dehydration is present. The side effects on the liver are, we have to use it very cautiously if patient's liver function is impaired. And the hypersensitivity effect of non-selective NSAIDs, because it is inhibiting the COX-1, produces the allergic reaction and asthma also. Next, please. So the risk factors for NSAIDs toxicity, we should know the risk factors so that we can avoid it in those patients who have the risk factors. So for GI toxicity, advanced age, high and prolonged use of NSAIDs, history of upper GI bleed or upper GI symptoms like acidity, or concurrent use of aspirin, steroids, or anticoagulants are all risk factors for GI toxicity. What are the risk factors for renal toxicity? Advanced age, poorly controlled diabetes, the presence of dehydration, very important risk factor for renal toxicity. The concurrent use of other nephrotoxic drugs like certain nephrotoxic antibiotics or something like that, or if the creatinine clearance is less than 30 ml per minute, then you can avoid NSAIDs. What are the risk factors for stroke and MI? They are advanced age, the presence of comorbidities like diabetes, hypertension, hyperlipidemia, smoking. In this case, you particularly avoid COX-2 drugs. Next, please. So let us discuss the COX-2 drugs. Like I mentioned, COX-2 inhibition is inhibiting the enzyme which is actually causing the adverse side effects like inflammatory reaction. So when you selectively inhibit COX-2, we are leaving the COX-1 aside and not interfering with that. So the COX-1 beneficial effects are remaining, and we are only inhibiting the adverse effects produced by the COX-2 enzyme. So the prototypes of the COX-2 inhibitors are etoricoxib, which is popularly called Nucoxia, given in a dose of 60 mg, 90 mg, or 120 mg. It's once a day dose. The other prototype like diclofenac, although it was considered both COX-1 and COX-2, functionally it is more COX-2. And it can be given orally or intravenously in a dose of 50 mg every 8 hours to a maximum of 150 mg per day. Next, please. So now that we know about the COX-1 and COX-2, are we saying that selective COX-2 inhibitors are safe as compared to non-selective COX inhibitors because it is not affecting the COX-1 inhibition? Now, it may not be 100% true. Where the GIT is considered, it is definitely beneficial, COX-2 inhibitors. But where renal damage is considered, it can be comparable to the non-selective NSAIDs. So both, it can cause renal side effects, the COX-2 inhibitors. But in addition, it has a prothrombotic effect. So that is one side effect of COX-2, which is quite a serious effect, and it is more likelihood of myocardial infarction and stroke because of its prothrombotic effect. Next, please. So the selective COX-2 inhibitor like rofecoxib, it was introduced, but it was taken off the market in 2004 because of these prothrombotic effects. So now it's no longer available, but Nucoxia is still being used provided there is the risk factors not there. Next, please. In fact, in 2010, there was a Danish study which showed that increased cardiovascular morbidity and mortality was observed with rofecoxib and diclofenac, because diclofenac is significantly COX-2 inhibitor. And the risk increases with higher doses and prolonged treatment. So in those patients who have risk factor for cerebrovascular and cardiovascular events, for them, the safest drug would be brufen or ibuprofen and naproxen, particularly in these kind of patients. Next, please. So the precautions, what are the precautions that you take with NSAIDs? First of all, you have to administer it with gastroprotective drugs like proton pump inhibitors like pantoprazole or rabeprazole. We should use it very cautiously in patients with acid peptic disease, advanced age, smokers, alcoholics, steroid treatment, because that can cause ulceration, CAD, hypertension, asthma, renal dysfunction, gout, a lot of contraindications. And the important thing is when we are giving NSAID, we must ensure adequate hydration of the patient. Avoid it if there is dehydration present. Avoid it when nephrotoxic drugs are being used, like when you're injecting dye for imaging purposes. Avoid it if there's a bleeding tendency or patients who are on anticoagulants. And also selective COX-2 inhibitors should be avoided in atherosclerotic disease, coronary artery disease, and cerebrovascular disease. Next, please. So that is all about the step 1 drugs. So let us discuss step 2 drugs. These drugs are given for mild to moderate pain, and these include, we can add it along with a non-opioid drug with or without an adjuvant. So you give step 2 along with a non-opioid drug, you may or may not add an adjuvant. Now the advantage of step 2 drug as compared to the step 3 drugs, it is not a controlled drug. Controlled drugs are morphine and fentanyl. So these drugs are more easily available and it can be widely used without any specific filling up of special form and all. So it is given for pain of moderate intensity that is not controlled with step 1 drug. But it can be combined with step 1 drug. But sometimes you can avoid the step 2 and go directly to step 3. So the examples of step 2 drugs are codeine, tramadol, tapentadol, and dextropropoxyphen. Next, please. So let us discuss tramadol because that is very commonly used by many practitioners, and whether it is for cancer pain or non-cancer pain. Now, tramadol has a dual mode of action. It is a weak opioid, so it blocks some opioid receptors. But besides that, it can also block the presynaptic uptake of serotonin and norepinephrine. So it increases the levels of serotonin and norepinephrine, and so it can be even given for neuropathic pain. And tramadol and paracetamol combination is very widely used as a step 2 drug. Next, please. Now, the advantage of tramadol is has got a very high oral bioavailability. Means even the oral dose is potent. Even in fact, it is more potent than the IV dose. So what is a dose? You can give it as 50 to 100 mg every 4 to 6 hours. The maximum daily dose being 400 mg. The IV dose is less potent than the oral drugs. It is 1/10 as potent as morphine. So if you look at the equianalgesic dose of tramadol with morphine, 400 mg of tramadol is equivalent to 40 mg or 80 mg of morphine, depending upon the whether it is a IV or an oral dose. So thumb rule is if you divide 400 mg of tramadol by 10, that will give the amount of morphine that it is equal to. Okay. Next, please. Am I clear? Am I audible?
Yes, ma'am, you are.
Oh. So there is another step 2 drug which is now getting a little popular, and that is tapentadol. This is a newer drug. Just like tramadol, it is a weak opioid, that is, it's a mu receptor agonist, but it is also got, like tramadol, it can inhibit the pain pathways that are descending, which is prevents the reuptake of serotonin and norepinephrine, and thus can inhibit the pain perception of pain. Its side effect is supposed to be superior to tramadol. The dose is somewhat similar, 50 to 150 mg every 6 to 8 hours with a maximum of 400 mg per day, which is around similar to tramadol. Next, please. Now, codeine is another step 2 drug. It is a weak opioid, but it is not available in India, and so I will not discuss this. Next, please. The other step 2 drug is dextropropoxifen. It was earlier very much available, but now it is not commercially available. And why it was not available? Because its sale was suspended because of concerns related to ECG changes. It was supposed to produce a prolonged QT interval. But now there is an appeal to the government of India to revoke its suspension so that it is more freely available. But as of now, it is not available freely. So the only step 2 drugs that we are using is tramadol and tapentadol. Now, if you look at the analgesic combinations that we use, we should never use 2 drugs of the same category for treating pain. For example, we do not combine a COX-1 and COX-2. Like, for example, you do not combine a brufen with a Nucoxia because both are COX inhibitor. So you use either brufen or Nucoxia. The other thing is you do not combine 2 opioids. Like, for example, a weak opioid like tramadol, you do not give it along with morphine. So either you give tramadol, or if the pain is not controlled, you give morphine, but then you don't have to give tramadol along with morphine. But what are the combinations that are effective is paracetamol, NSAIDs with morphine, or paracetamol with NSAIDs, like a step 1 drug, or paracetamol with tramadol, which is a step 2 drug. So these combinations are very effective for controlling pain. Next, please. So let us discuss the adjuvant drugs. Now, what are adjuvant drugs? Adjuvant drugs are, it is not primarily given for pain, but these drugs have analgesic properties. So they are called co-analgesics because they are given along with the analgesic drug of the WHO pain ladder. So there are 2 types of adjuvant drugs. One is a multipurpose and one is a specific. Next, please. What are the multipurpose adjuvant drugs? These adjuvant drugs can be given for a wide variety and wide number of types of pains. For example, if for example, pain is causing depression, or if there is a inflammation like steroids, corticosteroid, it can be used for a variety of conditions. Or sedatives or antispasmodics. Okay. Now, what are the specific adjuvant drugs? This is used for specific types of pain. Like, for example, if it's a neuropathic pain or a bone pain or a musculoskeletal pain or a bowel obstruction. So when these kind of pains are there, then you use these specific adjuvant drugs. So let us discuss some of these. Next, please. Now, a very important thing that we need to know is whether there is neuropathic pain or not. Like I mentioned right in the beginning, when you assess the pain, you have to see whether it's only nociceptive or neuropathic. Now, neuropathic pain can be present in up to 40% of patients with cancer. And why does it occur? Like I mentioned, it's because of an abnormal processing in the peripheral and the central nervous system. And the neuropathic pain is characteristic because the pain has a dysesthetic quality. What is dysesthesia? Abnormal pains. Like, for example, it can be burning, it can be shooting, it can be like an electric current, it can be allodynia. That means only touch can produce pain, or a touch can produce an odd sensation. So that is called dysesthesia or allodynia. This is characteristic feature of neuropathic pain, and you have to elicit it right in the beginning when you're assessing the pain, whether this element is there or not. Next, please. Why does it happen? It is because of either the direct invasion of the cancer to the nerves or because of the cancer compressing the nerves. So it can cause a mononeuropathy or a plexopathy. It can also be because of the neurotoxic effects of chemotherapy or radiotherapy. And that is called chemotherapy-induced peripheral neuropathy. Many patients who are on chemotherapy will complain of burning and difficulty in performing certain movements, fine motor skills, or they may have a current-like sensation or abnormal perception of pain. So it can be because of that also. Next, please. And there is clinical consensus that neuropathic pain are not very responsive to opioid drugs. So you have to add an adjuvant drug like an anticonvulsant or antidepressant to produce effective management of that pain. Next, please. So what are the most commonly used neuropathic pain drugs? Are anticonvulsants and antidepressants. The less commonly used drugs are local anesthetics, NMDA antagonists, corticosteroids, and GABA agonists. Next, please. So like the WHO pain ladder, we have a neuropathic pain ladder also. In that, there are 4 steps. In the first step, you use a tricyclic antidepressant with an anti-epileptic, with or without adjuvant. In the step 2, you have to combine a antidepressant with an anti-epileptic. Step 3, you give an NMDA antagonist like ketamine. And in step 4, you may have to give a local anesthetic like lignocaine. So depending upon the intensity of pain, you may have to go stepwise, even in neuropathic pain. That's called the neuropathic pain ladder. Next, please. So why are anticonvulsants used to treat neuropathic pain? Because it is a first-line treatment. Remember, anticonvulsants and antidepressants are the first-line treatment for neuropathic pain. Because the pathophysiology between epilepsy and pain are more or less similar. In both, there is neuronal hyperexcitability, and by giving an anticonvulsant, you're dampening the neuronal excitability. And the most commonly used anticonvulsants are gabapentin and pregabalin. Next, please. How does it act in neuropathic pain? These drugs combine with the voltage-gated calcium channel, in particular the alpha-2 delta subunit. And that is in the presynaptic neuron. So when the drug combines with this voltage-gated calcium channels, it prevents the influx of calcium into the presynaptic neuron. And when the calcium influx here is prevented, there is less release of the neurotransmitters, which are the excitatory neurotransmitters, which are activating the postsynaptic membrane. So less calcium, less activation. So that is how it is producing the relief of pain. So it decreases postsynaptic neuronal excitability. Next, please. So the commonly used drugs are gabapentin, pregabalin. What are the advantages? It has a proven analgesic effect in neuropathic pain. It is well tolerated, less chance of drug-drug induction. And the side effects that we should remember are it can cause somnolence, that sleepiness. It can cause dizziness, ataxia, fatigue. impaired concentration, and edema and weight gain. So that we should remember when you're giving these drugs. If you compare gabapentin and pregabalin, one is here the oral bioavailability is unpredictable, whereas in pregabalin it is predictable. And this varies with the dose. And so you have to start with a small dose and go in multiple steps to the correct dose, whereas here the titration to the effective dose can be achieved in 2 or 3 steps. This is definitely less expensive, whereas this is more expensive. So that is a comparison of the 2 drugs. And what are the other anticonvulsants that are used? Sodium valproate, very commonly used, and there are many other drugs, but for pain, we don't use it so commonly as compared to pregabalin, gabapentin, and sodium valproate. Next, please. Now, the other step 1 drugs for treating neuropathic pain is antidepressants. Like I said, this is a first-line treatment for neuropathic pain. So, antidepressant effect, the analgesic effect of these drugs are achieved at much lower doses than its antidepressant effect. It occurs earlier and at lower doses. How does it cause the analgesic effect? It actually inhibits the reuptake of norepinephrine and serotonin. So these levels are increased. And it can also cause endogenous opioid interaction. Next, please. Now we must remember that antidepressants are of 3 types. One is the tricyclic antidepressants. One is a selective serotonin inhibitor. That means it doesn't affect the norepinephrine. And the other one is the SNRI, which is both serotonin and norepinephrine receptor inhibitor. So please remember TCA, SSRI, SNRI. These are the 3 types of antidepressants that are available to treat neuropathic pain. Next, please. So let's discuss the tricyclic antidepressants. Now, these are of 2 varieties. One is a tertiary and secondary. The tertiary amines are commonly used as amitriptyline and imipramine. The secondary amines are desipramine and nortriptyline. Now, both classes have analgesic properties, but the tertiary amines have got more analgesic properties with more side effects. Whereas the secondary amines like nortriptyline has lesser analgesic effect, but definitely a lesser side effect profile. So it has got, one is more effective, but more side effects. The other one is less effective, but less side effects also. Next, please. What are the side effects of TCA? CNS side effects are, it can produce somnolence like sleepiness, drowsiness, mental clouding, and it can also have suicidal tendency. And the other side effects of TCA are because of its anticholinergic effects, antimuscarinic effects. They are, we should always complain of dry mouth. They can produce acute angle glaucoma. It can cause blurred vision because of the dilatation. It can cause tachycardia leading to cardiotoxicity, urinary retention, constipation. So avoided in patients with prostatic hypertrophy and those with already constipation. Next, please. So the contraindications of tricyclic antidepressants are avoided in patients with cardiac problems like conduction defects, arrhythmia, heart failure because of its tachycardia effect. Avoid in patients with benign prostatic hypertrophy. Avoid in patients with narrow angle glaucoma, as that can get aggravated. Next, please. So the other antidepressants I mentioned was SNRI and SSRI. They block the synaptic reuptake of serotonin and norepinephrine and thus decrease pain transmission through the descending inhibitory pathways. The prototypes of SNRI, which block both serotonin and norepinephrine, are venlafaxine and duloxetine and milnacipran. And only SSRI, that is only serotonin blockage, is paroxetine, citalopram, and escitalopram. Next, please. Am I going too fast? Am I understanding? Are you all understanding it? Yes?
Ma'am, I suppose we need to go fast, ma'am.
Okay, I've got only 5 minutes left, right?
Yes.
Okay, so if you look at the analgesic effect, then the TCS maximum effective followed by SNRI and followed by SSRI. But if you look at the side effect profile, tertiary amine has got more side effects, less with secondary amines and less with SNRI and SSRI. And like I said, the most commonly used TCA is amitriptyline, the most commonly used SNRI is duloxetine, and the most commonly used SSRI is citalopram. Next, please. So the antidepressant, you have to give in a dose of 12.5 to 25 mg. And if you give a gabapentin, it's a dose of 100 mg, and you can gradually step up to 1200 mg TDS in number of steps. Okay, not suddenly, but very gradually. Pregabalin, you start with 75 mg HS, then BD, and we can go up to 450 milligrams. Sodium valproate, start off with 200 mg HS, and then stepwise increase every 3 to 5 days up to 1 gram a day. Next, please. What are the other drugs used in neuropathic pain? NMDA blockers like ketamine. Okay, because ketamine is, I told you, this is a step 3 of the analgesic neuropathic pain ladder. How does it act? It blocks the NMDA receptor, and that is how it produces the pain relief. And the drug that we use is ketamine. Next, please. Next. So oral ketamine in sub-anesthetic doses of 0.2 to 0.5 milligram in a dose of 10 to 25 mg, which doesn't produce anesthesia but can produce pain relief, may be effective. It can also be given as an infusion in a very small dose of 0.05 to 0.5 mg. But the side effects are dysphoria, hallucinations, nausea, vomiting, dizziness. So it is always combined with a midazolam or a benzodiazepine. Next, please. Local anesthetics also are effective for neuropathic pain because it decreases neuronal excitability by blocking the sodium channels. So that can also be given as a step 4 drug of the neuropathic pain ladder. Next, please. Next, please. So you can give it as an IV infusion in a dose of 5 milligram per kg over 1 hour, monitoring the cardiac condition, keeping a monitor, and then if it is effective, then you can convert it to oral mexility. Next, please. So what are the other adjuvant drugs for neuropathic pain? I will not go through this, but the other drugs that we use for pain are, neuropathic pain are multi-purpose analgesics like bone pain, neuropathic pain, headache. So for that, you have steroids. Next, please. Previous one. Previous. Okay, one more behind. One more behind. Steroids. Now, steroids are very effective for a variety of conditions. The dose is 4 to 8 milligrams for 5 to 7 periods. We can also give as high dose, but when we are giving it, you must start with a low dose and the lowest effective dose, and we have to give the gastroprotective drugs concurrently. Next, please. Okay. GABA agonist also can be given, and that is baclofen. It is given when there are spasticity along with neuropathic pain. You start with 10 mg and you can gradually go up to 30 to 200 mg. Next, please. So the other drugs that we can give are topical local anesthetics. 5% lidocaine patch is now available, and that can be used when there is an allodynia or for neuropathic pain in a particular area. You have to apply it for 12 hours and take it out for 12 hours. That is one thing we have to remember. Next, please. For bone pain, you do palliative radiation when the lesion is localized, or we can give corticosteroids and NSAIDs, calcitonin, and bisphosphonates. Next, please. Bisphosphonates are very effective for bone pain secondary to breast and prostate cancer and for multiple myeloma. It acts by blocking the osteoclastic activity and the bone resorption. So it actually promotes the bone growth. Zoledronic acid is being given 4 mg IV every 4 to 8 weeks for treatment of intractable bone pain. The other adjuvant drugs are skeletal muscle relaxants like thiocolchidoside, dizanidine, chlorzoxazone, antispasmodics like octreotide, and anticholinergic drugs like hyoscine, butyl bromide, and glycopyrronium. We can give neuroleptic agents. These are all other adjuvant drugs that we treat for pains which have got some specific, or it could be lack of sleep, you give sedatives, anxiety, you give anxiolytic, if there's constipation, you give laxatives, or if there's infection, you give antibiotics. These are the other adjuvant drugs that you give along with your analgesic drugs of the WHO pain ladder. Next. So to summarize, the WHO analgesic ladder is the sheet anchor of cancer pain management. It can also be used for cancer pain, The advantages are the simplicity and the easy implementation of this regime. It's used worldwide, even in the remotest corner of the globe, and it has actually legitimized the use of cancer in treatment of both cancer pain and non-cancer pain. Thank you.
Thank you, ma'am, for the detailed presentation. Raju, I don't think I should summarize it now because it may take another 5 minutes. But I strongly recommend everyone. Those slides are very descriptive. If you just go through the slides, it will be much more useful than reading any other books, because in each slide she has mentioned exactly where it acts, what is the mechanism of action, the classification, everything. So just when you are getting that PowerPoint, please go through each slide. Everything is in detail. I think it's from many textbooks, so it has its own benefits of reading many textbooks. So please go through each slide when you are preparing for assignments or for your exam. Can we go to case presentation, Raju? I've written down the points for summarizing, but I think it would be better to go through each slide. It is very descriptive. Thank you so much for that, madam.
Most welcome. Thank you.
And thank you, Sister Pyrina, for volunteering this week. And I request everyone that we don't have to do it every week, I guess, to ask someone to do the case presentation, to present the patient story. So it will be mutual learning. So please come up with your stories every week.
Dr. Piorina, can you hear us?
Sridevi, can you hear me? Sridevi?
Yes, I can hear you. Yes, ma'am.
Do you want, before the case presentation, do you want to ask whether anyone has any doubts regarding the presentation?
I thought this presentation has a little bit of NSAIDs and pains things coming up. So I thought if it is coming up, then yeah. So that we can ask them what is their view about it, what do they think, so we can relate everything together they have heard.
Yeah.
Dr. Piorina? Dr. Piorina, can you unmute and speak? Dr. Piorina, can you hear us? Can you unmute from your end and speak? Ma'am, I suppose there is some internet connectivity issue with Dr. Piorina.
So till that time, can we take up some questions? And I'm sure, I don't know who asked last time about, we had a little bit of discussion about NSAIDs and tramadol during last week's presentation. So if we can bring up them. There were questions regarding SOS dose, about NSAIDs. I don't remember exactly who asked about, someone described a patient coming with pain, and I told next week we'll be dealing more with NSAIDs. So, or anything from Dr. Mary's presentation.
Dr. Nimi Vagis, I suppose you have a doubt.
Yes, ma'am. Last time I only asked about about the dosage of the tramadol, means like how means NSAID, use of NSAID, everything. Like it was a very informative class today. I could clear out many of my doubts. So,
what was the question? Can you just for every one of us to recollect and talk? Still, Sister Pyrina is ready.
If the pain is not relieved due to, means like initially we give diclofenac when the patient comes with the pain. So if the patient is not relieved of the pain anymore, means tramadol. Usually after the diclofenac we give tramadol, no. So if the pain is not again relieved with the tramadol, what else we can use?
Yeah, I remember that question. So I guess that question was answered. And you might have understood from Dr. Mary's presentation that you don't need to start from step 1. You can
Okay, ma.
if the pain score comes in a severe pain range, you can definitely start from step 3 or step 2. You don't need to start from the step 1 and then climb upwards. So wherever the patient's pain is, if it is severe, you can just start with the step 3. That's what Dr. Mary was mentioning about the flexibility of WHO analgesic ladder. It's not a rigid ladder. You can start. It should be according to the intensity of pain.
Okay, ma. Okay, ma.
And
Thank you.
also when you're giving diclofenac, why don't you combine with paracetamol even in step 1? You understand?
Yes, ma.
Given the
Yes.
proper dose of paracetamol and diclofenac in its full dose, if it's not responding to that, then you go to step 2. But you
Okay,
can
ma'am.
always combine these two drugs together, and various combinations are available. For example, combination of NSAIDs with paracetamol is available, or you can give it separately also.
Yeah.
So,
No,
ma'am,
Sridevi?
one more doubt. One more doubt. If we are
Yes,
giving
yes.
paracetamol plus diclofenac, the same dose we can give, or like we have to adjust the dose also?
No,
Like
you can give the
paracetamol dose
same
we
dose.
can.
Yes, you can give the same dose. 500 or 650 mg every 6 hours, depending upon the underlying condition. And diclofenac, if there is no contraindication, you can start with 50 mg BD, then go up to TDS, or maximum up to 150 mg a day. Okay.
Okay, ma'am. Okay, ma'am. Thanks, ma'am.
And I think before going to next step, you should optimize whatever medications you are using. Just don't give it like a SOS and then go to the next step. Give the optimum dose of all the medications, and then okay, even with the optimum dose, the patient's pain is not relieved. Then even that is the same case with neuropathic pain medication. Madam was mentioning a lot of classifications, right? And anticonvulsants, antidepressants. So there are a lot of combinations. So people tend to combine so many drugs together, and we don't know which one is effective. So once you start one neuropathic medication, assess the relief, whether this is
Okay,
helping,
ma'am.
not
Okay, ma'am.
helping. Go to the optimum dose. Think of, if not working, think about the alternate. If not working, just stop it and think about the next. So I think we'll get to know about all this when you